We detailed cultural discussions, genomic assessment of impact, so in the introduction, the word impact was derived from the Latin word impactus, the word means the according to its introduction, it is often referred as wisdom. Also, because of its introduction, we must commonly the concept of himself and its days impacted. In this logical removal of this phenomenon has been still correct method. Common procedures performed by neural application surgeons, both in clinical practice and hospitals. The assessment, the common radiograms that are used are OPG, internal, perioperative radiograph, occasionally lateral skull projections in CBCT and general. The intraoral perioperative radiograph, most of the most of the common radiographs that are done for identifying the impact of the molecule, which is not clinically visible, are intraoral perioperative radiograph. So most of the local factors that may cause difficulty in removal of the tooth can be determined by proper examination of this X-ray, that is intraoral perioperative radiograph. And the specifications for IUP are given by Winter was buccal linear cusp of the electric second volume superimposed. And the area of contact of the first and second molars must not overlap, and the film must be far enough back from the mouth to show only the distant root of the first molar. So the ideal radiograph will show the whole curve angular should be visualized and local factors such as angulation of the tooth in relation to the long axis of the adjacent intertooth bone, configuration of roots and peripheral pathologies of any can also be as a structural disadvantage of intraperipheral region. We need a occlusion view. So why you need a occlusion view? Because to appreciate a tooth in a three-dimensional way. Normal intraperipheral radiograph will let you see a tooth impacted tooth model in a two-dimensional way, where it is only seen the mesial-distal relationship can be appreciated. Whereas in occlusion view, the buccal view can be appreciated, and it can also aid in localizing the position of the tooth in case of difficult infections where the tooth is buccally or lingually tilted or rotated. As you can see in this picture, you can see a tooth with a third molar lingually having the cusp lingually towards the lingual side, so that the removal of the tooth has to be planned accordingly. Lateral skull perceptions. So what are these? Lateral view, lateral skull view. It is done prior to that to a panoramic radiograph where locally present. So when was it done? Before the invent of OPG, this was ideally done to view the mandible. That was the only option for viewing mandible infected that could not be seen through intraoral radiograms. And it has a greater periapical coverage, shows the amount of bone below impacted tooth in a true mandible. In most of the conditions, since it is given in certain angulations, lateral skull view can be a straight lateral set or a lateral cephalogram, or you can have a downward, that is a lateral view, which can be seen in the first picture, where you can appreciate the length of the tooth and the impact of the tooth can also be appreciated. So, analog behavior, this is the ideally done to appreciate the third molar. So it is indicated when it is indicated, this periodical beam may not possible because of the difficult in access positioning to the spot level and associated pathological process larger than that can be demonstrated in the peripheral form to the supposed to the mandible. And in case of any pathology associated, be it cyst or tumor, any of the associated factors which can be captured into in a normal intraoral periodical radiograph. Thus, OPG is indicated in those conditions. So after the advent of OPG, the use of lateral set on the lateral oblique radiograph have come down. And most commonly used radiographic view of appreciate multiple impacted tooth, be it maxillary impactable, can be seen in one XT, that is intra or orthopantogram. So coming to the determination, how do you appreciate the tooth in X-ray. So Winter's line of war lines are being postulated by Winter to understand the positioning of impacted tooth with respect to the norm. So the position depth of the mandibular third molar can be determined using Winter's line. It was given by George Ananth. So he divided the war lines into three different categories. One was white line, and W stands for white, K stands for amber, R stands for red. So the white line signifies the actual inclination of the molar. So it is drawn on the occlusal surface of the erupted molar and extended posteriorly through the third molar region. And the amber line, this is a line that is drawn from the surface of the bone, lying distal to the third molar to the crest of the inferior segment between the first and second molars. It is important to identify the bone distal to the third molar, as it can be easily be confused with a shadow cast by external optic ridge in the tree. So what is significant? It shows the amount of bone enclosed by alveoli. After reflection of soft tissue, the amount of tooth that lie above and in front of the alveoli will be visible. Coming to the red line, this is a perpendicular line dropped from the amber line to an imaginary point of application of the elevator. The point of application of the elevator is always on the CDJ, on the mesial surface of the impacted tooth, exception in the distal angular tooth, which is distal surface of the impacted tooth. So as a general rule, any tooth with a red line fill 5 millimeter or more in depth, better to be removed under general anesthesia. 9 mm or more, the inferior surface of the crown of the impacted tooth may be close to affect of the second molar. So the chances of denuding the second, which is second molar tooth, is considered. Removal of second molar is also considered if the red line is surpassing even 10 mm or 9 mm. And the significance is the length of this line is indicated by the depth of the impaction. So the increase in 1 mm length shows the 3 times increase in difficulty of the action. So as you can see, the entire thing, war line has been demonstrated, and the point of elevation can be appreciated in different ways. So for mesioangular impaction, the point of elevation is in the anterior region, that is the mesial surface of the mesial CJ points in between the junction of your impacted tooth, whereas for distangular tooth, the point of elevation is at the distal 7 to junction of the tooth, impacted tooth. Whereas for horizontal tooth, the point of elevation is again the mesial point CJ. Whereas for a vertical tooth, it is the central region, the CJ or the central part of the impacted tooth. So based on the classification, you can understand the mental burdens, how it has been postulated. And path of withdrawal is the path of withdrawal is along which the tooth would be move accordingly to its position in the curvature of the roots if it was able to erupt unimpeded into the mouth. So considering the roots are favorable, the path of withdrawal for a distal tooth is upward and backwards, and for horizontally impacted tooth is forwards, for mesioangular tooth is upwards and backwards, and for vertical tooth is upwards and straight upwards is what vertical tooth would be. So after seeing the winter variants, we go for the number of roots, shape of roots, presence of abnormality, and all these things can be seen in the fluorescence. So seeing on the root pattern, you should have to understand how many roots are present, shape of the roots, presence of any abnormality in the root, favorable, unfavorable root pattern, which we will explain in a couple of slides in front, and conflicting path of withdrawal. So you see the shape of the crown. A large square crown with a prominent cusps are more difficult to remove. And due to the retraction, the path of withdrawal of the impacted tooth is obstructed by the crown with adjacent tooth. So, position of the root pattern of the second molar also competes with the removal of third molar. So, the distal plate of the lumicus of the second molar can create an hindrance and removal of the tooth. A single coronal root of a second molar can lead to increased chance of laxation of second molar later in the third molar. So the root pattern of the second molar can also affect the way you remove the impact and the texture of the investigation. So it can be assessed using an IOPA or even using CBCT. So if it is a cancerous place at large, the bone structure is fine, the bone is usually artistic. And discriminating bone increases the difficulty of surgical operation. When a size of bone is wide follicular sac, the impaction tooth can be removed easily, whereas the follicular space is small, the tooth becomes more difficult to remove. So coming to the Root's criteria, it's given the JB root. So he is given some categories in which radiological prediction of the inferior alveolar injury during the third molar surgery. So he has given the darkening of the root, deflection of the root, narrowing of the root, uh, dark and light root, interruption of the right line, the equation of inferior alveolar cancer, narrowing of the inferior alveolar cancer. All these are some of the features of the root formation is seen by roots, and in that was the discontinuity of the white line is considered to be one of the threatening one because if there is a discontinuity of the white line is seen, then there is a chance that there is a communication between your inferior alveolar masculine boundary and your root surface. So while removing the third molar, you may encounter inadvertent bleeding due to the disruption of continuity of your inferior vascular boundary. That is having inferior alveolar tree along with your inferior. So thus, in those conditions, when you suspect that kind of a radiographic finding, then it's always better to go for control procedures like coronectomy, or you can wait for the, or you should have precautious methods, so which can stop the bleeding if in case if you injure neurovascular bundle. Signs related to knee injury, that can be the diversion of the inferior canal, darkening of the root, and interruption of the right line. Signs unrelated to nerve injury are narrowing of the root, darkening of the root, narrow of the inferior canal, and the deflection of the root. So the based on these things, two is the assessment by the system, where Winter's classification, height of the mandible, angle of the second layer, the root, showing and away and the height, the follicle of the tooth, and the exit. So again, in the there is also something called a quantitative classification of anatomical relationship between impacted third molars and the apical bone. So it is Cartesian coordinate system from continuous buccal slices where the inferior velar or the lower molar were closest was selected as a reference to show the relative position. So as you can see in these things, the contact and non-contact of the tooth with respect to your cross section of the nerve and the tooth can be appreciated. So in the based on that category, the relationship between inferior vermium and the third molar using Cartesian coordination system. So there is buccal, you have 3 contact and 9 contact. So the chances of finding more contact is where the buccal contact is 8.8%, whereas lingual contact is 11.7%. The root, the canal being present in between the roots is 0.7%, and whereas if it is inferior to it is more than 78%. So the maximum what we would encounter is the canal that is inferior to the roots of the tooth. But whereas there are still charge where the canal can be lingually present and it can be buccally present. In those conditions, CVCT evaluation would be advised, which can help you aid the position of the aid to understand the position of the inferior alveolar canal with the roots of the tongue. A thorough knowledge of research anatomy and radiographic assessment of impacted mandibular third molar and the surgery can help minimize the complications associated with surgery.